I've never felt so acutely like I've stood in between people and going to the pub. I will I will be mindful of the time whenever I'm speaking to you today. So not surprisingly, I'm going to talk about the COVID-19 pandemic, and specifically I'm going to talk about the HSE, which is the Health Services Executive in the Republic of Ireland's response to the COVID-19 pandemic. So over the past 20 months or so, around 11 million vaccines have been delivered in the Republic of Ireland. So that equates to about 16,000 vaccines per day. And if you think of the amount of data that's associated with those vaccines, data coming into the system and then data coming out of the system, we're talking about considerable data volumes. So when COVID-19 struck, governments around the world were plunged into crisis mode. There was neither the infrastructure there to handle the data volumes, nor the reports built for the types of ad hoc data requests that were coming through. A bit of the story that people maybe aren't as familiar with is how EY supported the HSE in Ireland through their journey of dealing with the COVID-19 pandemic, and also their own journey in the analytics maturity pipeline. So I'm going to introduce myself and my colleague Alexios. I'm going to give a high-level overview of the story of the work that EY has done in partnership with the HSE. Alexios will take a bit of a deeper dive on the capacity modelling, demand and capacity modelling, and I'll summarise by just telling you everything that I've told you before, as you're meant to do in a presentation, and also talk a wee bit about what EY is hoping to do in the future. So my name's Georgina. I haven't been in EY very long. I've only been in the firm 2 months now, and I'm in the data sciences team. I'm a manager there. Prior to joining EY, I worked as an epidemiologist. So that's bread and butter every day would be statistics, determining the risk factors associated with diseases, and then building predictive models to try and predict the outcomes of people, cattle. I was working on the cattle system with these diseases. Alexios?
Yeah, so I'm Alexios Sofias. I'm associate in the data analytics team in EY. Prior to joining to EY, I did a master's in financial technology, which is like a combination between finance and data analytics. And prior to that, I was electrical and electronic engineering. So I joined EY like 8 months ago, so I'm pretty new as well.
So just to give a wee bit of an overview of EY's operations in Ireland. So at the minute, we've got over 200 data analytics professionals and growing. It's not just our offices here in Belfast, but there's offices in Dublin, Cork, and a number of other locations. We have alliances with various technology partners, including Microsoft and Adobe. Our bread and butter day-to-day would be using SQL, Python, R, and then tools like Tableau and Power BI for data visualization. There's 3 main workflows or work streams, I would say, in our part of the business. There'd be the data engineering work stream, so moving data in between source databases, data warehouses. There's the data visualization professionals, and they're the people that really derive that business value and business insight from the data on dashboards and visualization tools. And then there would be the data scientists like myself, and we would analyze large data sets to bring forward insights that would not initially be clear, and the whole AI and predictive modeling side of things would come under our remit too. Bit of data analytics 101 for those people who aren't familiar. So depending on who you talk to, there's 4 main steps in the data analysis pipeline. First thing you need to do is acquire data. And that could be from other source databases, maybe from GIS data, flat files, whatever you've got sitting around in servers. Next, that data needs to be brought together. It needs to be cleaned. The duplicates need removed. We need to do some awkward joins between source systems. The data needs to be stored somewhere in data warehouse or data lake. And then next is the fun bit, which is deriving those business insights. So you could be looking at which customer segments do we want to target, or can we predict outcomes? So for example, can we predict the probability of an individual in this room having COVID-19? But data is expensive to acquire, it's expensive to store, and it's expensive to manage. So if you're going to all this effort and expense of collecting up these data sources, you better make sure they're doing the legwork for you. And this is what I want to talk about today, is really establishing that end-to-end data pipeline in partnership with the HSE. So as I mentioned, whenever COVID-19 struck, governments across the world were in absolute crisis mode. EY stepped in to work with the HSE and data partners, such as Microsoft, to plan out the next steps in response to the pandemic. And that involves everything from changing how things happened within the HSE, so pivoting to that agile methodology, to establishing the data architecture, pushing out information on vaccine uptake, contact tracing, building predictive models, and then lastly, deploying COVID certificates. So it's really, if you think of something to do with COVID, be it the contact tracing, COVID certificates with the HSE, then EY has been involved in that. And it was established in less than a month. So I'm going to show you on the next page the architecture of the system, and it is considerable. The first COVID case was confirmed on the 28th of February. Less than a month later, the solution was standing and operational. A solution of this size could sometimes take months or even years to implement. So the fact that this was turned around in less than a month shows the agility at which the team was able to pivot and work and under very challenging conditions, because policy was in the air as well. People weren't working from home, they were working from home. It was very challenging times. So for the team to be able to deliver this solution in such a short space of time is tantamount to their talent. Here is an overview of the data architecture. I'm going to put my hands in the air. I'm not a data architecture person, so don't put the difficult data architecture questions to me. But to give a bit of an overview, there's no source systems coming in. There's data from labs, from hospitals, from government departments. They have to be aggregated into the data lake. And then you see there's users accessing a suite of Power BI dashboards. And then later you'll see that some of the vaccination data was fed into that system too. So as I say, this was up and operational in weeks as opposed to months or years. And this whole workflow was supported by agile practices. So we also supported our partners, not just through technological change, but an operational change and a project management change in how they would approach this type of issue. Here are one of the dashboards for the contact tracing program. So we all remember track and trace, don't we? You got to ping on your phone if you're in close contact with somebody. EY worked closely with the HSE to deploy this solution. So you can see there's interesting insights that can be brought forward from that data. There's a bit of a spatio-temporal analysis there. Where are the close contacts in space and in time? You can look at the number of occupied hospital beds and then the number of occupied hospital beds that were occupied by patients with COVID-19. So those data that were being reported on day and daily were being fed through these dashboards that were developed for the HSE. And the big benefit of this, and it's also a really nice data set that I'll come on to later, is that you've got visibility of COVID patients from end to end of their life cycle. So if they think they've got COVID and they book a test, to the swabs arriving, to those test results arriving, to them maybe having to end up as an inpatient, you've got a full view of that patient over their life cycle. And our data and our insights were so trusted that we ended up reporting on close contacts for the reopening of primary schools. And we also set the scene for some predictive analytics and network modelling that I will come on to very shortly. Of course, after contact tracing, there was the vaccination rollout. Now, the big win here was that we were able to deploy the vaccination implementation on the same architecture that the test and trace was deployed upon. So there's efficiency savings and also financial savings to be gained there. But in addition, you're bringing two really cool data sets together, where you have the data on test and trace and who's positive and who's not. You've also got the data on who's vaccinated and who's not. So you can start to do really interesting things like serially testing populations. So that's when you give, you test the same population over and over again. Or you could even target the vaccine hesitant, with different messaging if it's clear that there's one segment of the population that maybe aren't as highly vaccinated as we would need them to be or as we would expect them to be. We also brought the HSE along on the analytics maturity pathway. So, you start off with descriptive statistics. What happened? What's the mean number of customers that do X, Y, Z, or what's the age profile of people with COVID, for example? So you start at the basics. Then you start looking at the diagnostic analytics. Why did something happen? And that may mean you have to take a bit more of a deep dive into the data and start thinking about what questions you want to ask of the data. And then the bit that I'm going to focus on today is the predictive analytics, which is, well, what will happen? And then, of course, there's prescriptive analytics. So can we make it happen? But mainly, it's the predictive analytics that I think is most fascinating and I have most expertise in. So for the HSE, we delivered a digital twin model of the whole operations of test and trace. And if anybody was down with my colleagues at the EY stall today, they were demoing a digital twin model for the manufacturing industry. But it's the same principles. You know, you simulate a system and you assess where the bottlenecks are, and then you fix those bottlenecks. We also did some demand and capacity modeling, which Alexios will come to later. We modeled the impact of vaccination on acute inpatient stays. And the bit that, if you're going to allow me to dive into a little tiny bit of graph theory on a Saturday afternoon, we also, sorry, it's only a little tiny bit, I promise. We also built some network models, and that was to identify contact chains in the system, and then you identify those nodes or those actors that may be high risk. Now, I can't talk about that in detail, but I will give a really kind of gentle toy example of the types of things that you can infer from a network model. So over here, I have 5 friends, Bonnie, Shweta, Fatima, and Kira, and Chen, who phone each other every week. So what we have is person A, the person who made the phone call, person B, the person who received the phone call, and then lastly, the number of phone calls throughout the week. So that table is a nice but not very useful or helpful way to represent those data. So what I have here is what you call a network model or a social network analysis, or a graph model of nodes, which are the actors connected by edges, which are the connections between those actors. So if you go to Chen has an in-degree of 2 because both Bonnie and Fatima will call Chen, and if you look at the table, you should be able to see that. However, Chen doesn't phone anyone, so she has an out degree of 0. So in this example, if you think of maybe this is information moving around the system, don't think of it in so much as disease. Chen is a good person to receive gossip, but she doesn't necessarily gossip about other people. But if you look at Bonnie, for example, she also has an in degree of 2 and an out degree of 2. So she's quite a good person to both give gossip and receive gossip. So in degree and out degree are 2 ways of looking at how connected these actors are in the system. You can also weight the edges. So you'll see that looking at Chen, Fatima phoned Chen 5 times. So that edge between those 2 nodes can be weighted thicker than some of the other nodes on the system. And then, of course, you can look at centrality measures. It's like, well, who's actually really important for spreading the gossip? And if you look, it's Bonnie is one of the most central actors in this system. So if somebody's spreading gossip, it's probably Bonnie. Gossip tends to come to Bonnie, and gossip tends to come from Bonnie. So if you can think about how useful this would be in the context of epidemiology and disease modeling, you can start to figure out who's important in your network model for spreading disease, and then start to ask, well, what if we targeted those people by removing them from the system, such as if we're asking these people to stay at home? You can get a really good oversight as to how you can improve the outcomes, the health outcomes for this population. That's me done with graph theory. Thank you for your patience. And the last bit that I want to touch upon is, EY supported the HSE through deploying of digital COVID certificates. There's been over 8 million COVID certificates deployed to date in the Republic of Ireland, which is no mean feat to get that infrastructure up and running, and then, link them back into the health records and the complexities that come with that. So I'm going to hand over to Alexios now, who's going to do a bit of a deeper dive into demand and capacity modeling.
So next we want to do a quick deep dive, kind of very high level of what we have done in regard of demand capacity model. So probably we have to explain what it's like a demand capacity model. So we want to forecast the hospitalization occupancy levels during the COVID-19. And this was kind of very important to us because we want to inform the HSE and all of the stakeholders as soon as possible in order to be prepared what is going to happen next. And when we did that, it was since March 2020, it was straight as soon as COVID started. We stood up the platforms and we done a lot of the analytics. How we did that? We used different techniques, including proportional modeling and time series analysis. At this point, we're still working towards this kind of model because we want to adapt all of the changes that COVID happens every day. So if we want to give a better understanding, an overview of what kind of data we used, we received daily the number of cases from the HSC, and we had the age profile of this number of cases, and also they provide us the forecasted number of cases. So we had all of this kind of data that we could work on and see and find patterns about the hospitalization rate. In the beginning of the COVID, the hospitalization rate was 5 or 6%, but throughout COVID it was around 2%. So we want to find the number of hospitalization admissions each day, and we want to find out the severity of illness and the age profile of the patients. And the most important part was to find out how long patients are going to spend in the hospital. So in terms of the modeling process, first of all, we had the forecasted number of cases every day and the hospitalization rate. This was a number that we evaluate every day based on the new data that came to EY. And then we had to group the hospital admissions by age. We had 3 age categories. And then we create 4 different severities as well, which was the moderate, critical, frail, and critical death. And then we had to summarize everything together in order to see if the overlapping is gonna be a problem for the HSC. So we wanted to show you a kind of illustration about how we can map all of these kind of assumptions. So first of all, as you can see, if we have 10K cases a day, only 2% of these are gonna be admissions to the hospital, and 50% about this is gonna be age between 0 to 50. So we are gonna have 100 patients, which the 90 of them are gonna be moderate, 1 of them is gonna be frail, 8 of them are gonna be critical, and 1 is gonna be critical death, unfortunately. And as you can see on your right-hand side, we have the time that they spend in the hospital. So as you can see, the moderate one, they spend around 3 days in the acute care, and then we could go back to their home. In the frail situation, they spend around 10 days in the acute care. In the critical, they spend 1 day in the acute care, 6 days in the critical care, and then should go back to the acute care for 4 days and then back home. And unfortunately for the critical death, they spend 3 days in the acute care and then 9 days in the critical care. As you can see in your left-hand side, you can see the age groups that we had and the severities. And we want to show you as well the model performance. So as you can see, we want to forecast what's going to happen in the future in terms of the acute admissions and the daily ICU admissions. So as you can see, the model performed really close to the actual results. And we also had the problem that in the beginning of COVID, we had the Delta variant, which was kind of more severe. So as soon as the Omicron variant came to Ireland, it wasn't as severe as Delta. So we had to adjust our models because as you can see in your left-hand side, it was kind of off. So we had to find a way to re-examine our kind of assumptions and understand what's the new disease performs like. So based on all of the calculations that we had made, we had adjusted to the situation. So you can see in your right-hand side, it was fairly accurate as well. So in terms of model evolution, we still trying to find up-to-date involving the hospitalization rate. We're trying to examine that every day. We examine as well the severity of proportions, how many it's in the critical care, it's again 3 days, 4 days. We have to re-examine again the length of the stay in the hospital. And again, we're trying to learn more about the disease and the COVID, and we're trying to re-examine our model's assumption. So I'm gonna give it back to Georgina in order to conclude of what we have done and what's next for EY and the HSC.
Thanks very much. It's okay. So, I told you I was going to tell you, I was going to tell you, I was going to tell you, and then I'm going to tell you it again. So that, hopefully you're going to take away that, EY supported the HSE not just through a technological change and installing that data architecture, but we also, supported how we think about data within that organization and really pivoting in that very agile way to deploy agile technology on the Azure data platform. All the main components of the pandemic, or at least solving the pandemic, from test and trace, the vaccine rollout, the deployment of those COVID certificates. We worked with our partners in the HSE, and we delivered a quality service. I mean, at one point we were pretty much advising the government directly, so it wasn't like we had a backseat with our feet firmly under the table, and we were providing quality insights and quality analytics to our partners. Alexios has explained how we built models to understand how patients move through the healthcare system, which is so critical. When you need to know how many beds are going to be available, not just now, but in 2 weeks' time, in 2 months' time, that's really a need to know information that we brought to the fore. And we also accurately modelled the hospitalisation rate during COVID-19, which again has a role in that, capacity planning and workforce planning. And our work with HSE, with that particular piece, is still ongoing. So we're still contributing to to support the system through the transformation of healthcare, and that's in resourcing, outsourcing, and drawing down funding. And that's with the scheduled care transformation programme. I'm not sure if anyone has had the time to visit our stall downstairs, but we've introduced the AI lab, and that's us really striking out to deliver advanced predictive analytics and artificial intelligence to our clients. As I mentioned, there was a digital twin model that was being demoed downstairs. I'm not sure if it's still up and running. No, unfortunately not. But I'm sure there will be other opportunities. It's a really nice demo, and we have other pieces coming forward on space tech and speech recognition. So it's all there. So look, I think that's us done for now. I think we've got one more talk before you can go to the pub.
Yeah.
All right.
This is the last one. Yeah, we did. Like if you want to ask.
Yeah, happy to field any. Yeah, I won't be able to answer all of them because I wasn't directly involved in all this work, but I'll answer as best I can. And if there's something I can't respond, I'll get back to you. Yeah. Hopefully no more pandemics. Don't say that. So I would say there's definitely scope to reuse components of the system. I can't answer your question directly because I don't have sight of that side of it, but certainly with the architecture that was deployed, bits of it were reused. The contact tracing was reused then to bring in that vaccination data. I would say there's scope. There's certainly components of it could be delivered not just the HSE, but other clients in the healthcare sector.
I'm just curious, the other big story that was the IT story that the HSE were involved in the last few years was the big ransomware attack that got caught up in. Did you find any, I think that would have been before you were involved with them, but did you find any lingering impacts of that?
That's one I can't answer. I would have to take that away and come back to you. No, it's I wouldn't necessarily know the answer to that. Is all the information and insight that I would have had was been on the deployment of the healthcare transformation. Yeah.
Would these sorts of approaches still have value in a public health setting, like dealing with a disease like meningitis, where you don't necessarily have the same data volume? Would something like this still have value?
Sorry, I've been forgetting to repeat the question. So the question there was, would this approach still have value, even if it was for another pathogen such as meningitis that, there's maybe just not the same prevalence or the same number of cases coming through? I would say a lot of organizations could benefit from thinking about things in a more agile way. I've worked in the public sector myself, and things can happen very slowly, and I appreciate that. And it is difficult to pivot to meet the needs of healthcare emergencies and other types of emergencies. So I would say there's definitely a case to be made for thinking about things in an agile format. Oh, sorry, yeah.
Certifications such as medicine as a service and certification of AI, how has that been implemented into the new AI cluster that EY has
Again, that's one I will have to get back to you on. I'm so sorry. So their AI offering at the minute is mainly focusing on the space tech side of things and the digital twin models. So the healthcare component is still, I know it's still a work in progress, and we haven't hammered home some of the details on that.
It's something that we are keen to
Yeah.
So basically our practice is based out of Dublin, so we are trying to showcase the primary to target manufacturing, but certainly from our sorry for HSE.
No, please go ahead.
No, for HSE is something that we are trying to expand on. We decided to mention the
Yeah.
Hi, so I saw the slide about the, severity, being able to predict the amount of time and things like that. Obviously, you trust the HSE to do the right thing there, but in other circumstances, that can be used to say, well, these people are a write-off, let's not bother treating them. Things like that. Is there any concern about the ethical side of things here?
So that's a question around, are we concerned about how patients are going to be treated within the hospital system and making sure that patients are treated in a way that adheres to ethical standards? I think that's maybe more of a question for medical professionals, but I would say that I can't see how it would necessarily be abused because there's so many checks and balances in place. No more than any other, any other bit of the healthcare system could be abused by people that, go on killing sprees, for example. I know has been in the news recently. I absolutely appreciate that. So I would say no more than anything else. And, I know there's work that goes on within the hospital sector itself, looking at whether there's clusters of deaths at certain spaces, certain spatiotemporal points. So I would say, although that's where work is retrospective, hopefully any anomalies would be detected before, any sort of major crises are arrived upon and the news hits the headlines. Is that us?
I think that's us now.
Thank you.